Okay, good afternoon, everyone. Thank you very much for joining this CASAP, so Children's Acute Surgical Abdomen Programme project team update and relaunch webinar. So my name is Ramani Munasinger. I'm the Chief Investigator for CASAP and the Director of the Health Services Research Centre at the Royal College of Anaesthetists. I'm grateful to the events team and the HSRC team for hosting this webinar today, and to all of you for giving up a bit of your time to come along and hear what we're doing and where we're going. I've got a couple of housekeeping things to start with. So we are recording the session, and it will be available to view on the HSRC webpage after the webinar, so people can come back and watch it later if they need to. The second thing is we want to try and wrap up before an hour, but after having had some questions and answers from you guys. So if you would like to ask a question, please put it in the Q&A. There's a Q&A function if you hover your mouse over the bottom of your screen. You'll be able to enter questions into the Q&A, and I will answer those, or a member of the team will answer those towards the end of the webinar. So I'm going to start. I'm going to try and share my screen now. Okay, so I'm going to start by giving you a bit of an update on where we are with CASAP and where we think we're going. And then I'm going to hand over to Cyrus, who's one of our research fellows who's been working very hard on CASAP, predominantly in sorting out the information technology, so the REDCap system and the CRFs and so on, who's going to give you an update on how to upload the patient identifiable data spreadsheets, which we really need in order to be able to get the maximum value out of the study. And I'll come back to the reasons why for that later. And then I'm going to, towards the end, hand over to Macie, who is one of our other research fellows, who is the person that's going to be responsible for most of the analysis. And Macie is going to give you a teaser of the results that we've collected so far, just so that you can see the value of the data that you guys are collecting, and the importance of it for the future of paediatric emergency abdominal surgery. So we hope that that will inspire you to get restarted if you haven't been able to, and to continue your efforts if you have. And before I go any further, I just want to acknowledge the incredibly difficult year that everybody will have had, both professionally and personally. To say thank you for your continued support for CASAP and also other HSRC projects, if you're involved in them. And really just to say thank you. And we understand the pressure that you've all been under, but we're really, really hoping to move forward positively with this study now, and take you with us towards the end of the study, which will come next year. So where are we today? So CASAP, just to remind you, is an NIHR portfolio adopted study, which is looking at the quality and outcomes of care of children undergoing emergency abdominal surgery. So it's a consenting study. There's no interventions per se. We're recording data, routine data, which you guys enter, which relates to the quality of the care the child has received. And children are defined as people aged between 1 and 16 years of age on the date of surgery. Sorry, just a few mouse issues here. There we go. So to remind you, these were the aims and the original research questions, with an additional one added at the bottom there. So what we're doing is we're measuring a whole bunch of data, including some risk factor data, so the sort of demographic details and clinical history of the child, but also we're measuring a whole load of processes which have been recommended for the delivery of clinical care to children having this type of surgery. And what we want to do is to record what compliance is like against these process measures, and try and develop an understanding of whether these are valid processes for outcome in this type of surgery. The second thing that we want to do is to develop and internally validate a risk prediction model, which can be used for children undergoing emergency abdominal surgery. And then the third thing that we want to do is that through this study, we want to determine whether it's feasible to run a longer term national QI programme, a bit like NIAA or a bit like PQIP in adults, but in this patient group of children undergoing this type of surgery. So amongst our research questions are included questions about the level of compliance with these international and national recommendations for the care of these children, to try and understand the risk factors for poor outcomes in these children. And then the third research question, which has arisen as a result of what's happened over the last year or so, is to understand what, if any, impact COVID-19 has had on the quality of care received by children undergoing this type of surgery. So, like every research study, we've undertaken some protocol changes in order to try and make the study feasible in the COVID era. So there are two things really. The first is that remote consent is permitted, which is obviously very, very important in order to reduce face-to-face contact where it's not necessary. And then the second thing is that we got an ethical amendment to say that if you were to be able to get retrospective consent and data collection for children who underwent their surgery after the beginning of the pandemic, which we've defined as the 1st of March 2020. Now, we've had a few queries about whether retrospective data collection can go back even before your site got the green light to participate, and the answer is no, it can't. So the your green light date is the first date that you can recruit a child. So the first date, so a child, only children that have had surgery after your green light date can be recruited, but you can recruit those children in retrospect. So even if they've had their surgery and gone home, you can retrospectively contact the family to see if it would be possible to recruit them into the study. So the study progress so far, so we've recruited almost 1,700 patients, and we've got over 80 hospitals participating. Some hospitals have not yet restarted since COVID came, but we're really, really hoping that every hospital that has had a green light will continue to recruit and start at a time that they're able to. Our target recruitment originally was 5,000 participants, so we're 25% of the way there. We will close the study on the 31st of January next year. So even if we haven't got to 5,000 patients, we will close the study then. But we really hope that as things start to pick up again in terms of research activity for non-COVID studies, that we will be able to pick up recruitment again. And we've got some really great exemplars of high recruiting sites who've been able to get really good engagement between not just anaesthetists and research teams, but also surgeons, in order to try and recruit lots of patients. And there are lots of lessons to be learned, and some of those went into our newsletter very recently. So do read the newsletter that we sent out, and do contact us if you've got any queries, or indeed any top tips to share about recruiting patients. So I'm now going to hand over to Cyrus, who's going to talk about how to upload the spreadsheet which contains patient identifiable data. So one of the things that we intend to do after the end of the study is to link the data that you have collected at the hospital with national administrative databases. So that's HES, Hospital Episode Statistics, and also the National Mortality Register, so that we can track long-term outcome in these children. But in order to do that, we need participant identifiable data. And so that's why it's really, really important that you submit these spreadsheets to us. And Cyrus is now going to go through the process for doing that. So I'm going to stop sharing my screen and hand over to Cyrus. Thank you.
Thank you, Ramani. So this should be a fairly quick presentation just to go over the process by which you can upload your patient identifiable data spreadsheet so that we can receive it here at the CASAP study team. As you know, the patient identifiable data spreadsheet has been kept separate from the main data, with the majority of data which is being entered into the REDCap web tool. And that's basically to satisfy the information security requirements that we needed to, the standards that we need to keep. So that data which constitute questions 1.1 to 1.8 on the paper CRF are currently being stored by you guys locally in the PID spreadsheet. But as Ramani has explained, there's some key information, for example, the date and time of admission, surgery, and gender, and things like that, that we would quite like to analyse. And the way that we can get that data is by an upload process using our file transfer portal, and that will get that data into our secure database. So that's an image of the spreadsheet that hopefully you've been populating over time as you're recruiting patients. And these are the questions which are going into that spreadsheet from the paper CRF. So the key dates are that we're hoping to get your data from, basically get the data that's complete up to the 1st of July 2021, and we'll send you an email, the local PI, an email to with an upload link. So that'll be the first time that you'll be sending the PID spreadsheet over to us. And then we will also request at the end of the study recruitment, which is 31st of January 2022, we'll request the final PID spreadsheet from you, and that'll be via another email. So the email will look like this. So very simple, there'll be a link, and when you click on the link, you will come to a web page, which is again a simple form that just asks you for your hospital site, and then a link that you click on to upload your file. Just to note, make sure that it is a secure site that you're going to, and it is this link. So it's slightly different to the REDCap link that you've been used to with the web tool that we're using, because this is going into a slightly different, more secure area of the UCL servers. Again, you just choose your spreadsheet, and it should say that the file was successfully uploaded. And I just ask that if you remember, once you filled in your hospital site and done that process, if you just click submit at the bottom of the form, you should get this message saying thank you for submitting your PID spreadsheet to the CASAP team. And if there are any problems, just let us know via the CASAP inbox if you're having any issues uploading the data. And as I said, the key dates are, you'll get a link just after the 1st of July to get, so just make sure that your spreadsheet is kind of up to date up to that point. And then you should get another link around the end of recruitment to get the final data set from the PID spreadsheets. So that's about it for me. So I'll be hand back to Ramani at this point.
Thank you, Cyrus, very much indeed. So if you could stop sharing your screen now, Cyrus, thank you. I'm going to hand over to Macie in just a second. We've had some questions in the Q&A come up already. Thank you very much. Just as a quick reminder to everyone, the study generic email address for contact is casap@rcoa.ac.uk. We'll put it in the Q&A as well. If you go to the front of the protocol, there's a list of important study contacts at the beginning of the protocol, as is usual, and the contact email addresses and so on are in there as well. And we have the study website, which I won't read out, but I will put in the Q&A, just so that that's got all the documents, everything you need, all the amendments, and so on it. So that should hopefully be your sort of first port of call for any queries that you might have. So I'm now going to hand over to Macie, who's going to give us a little bit of a taster of some of the results that we've got so far on a very sort of high level overview of the first 1,000 patients, which I hope you'll be really interested in. So thank you very much, Macie.
Thank you. I'll just share my screen. Okay, so hello, yes, my name is Macie. Thank you, Ramani. I have been one of the paediatric preoperative medicine research fellows at the college, the HSRC at the college for a little while now, and have been involved in CASAP really since its inception. So I'm going to present the first sort of 1,000 cases, it's slightly more than 1,000, just a little bit of descriptive epidemiology, so explaining what the lay of the land is, who these children are, what's happening to them, and what their outcome measures are. And also, just before I do, to really say thank you very much, reiterate Ramley's thanks, because I'm actually a PI at my own local site, and I have first-hand experience of the amount of work that goes into collecting all of this data. So I really appreciate it. So thank you to all of you and to your teams who are helping out. So in terms of the first 1,000 cases, that full data sets we have, median age for these children is about 11. Vast majority of them are Caucasian, with a few from some of the ethnic minority groups, and the vast majority really falling into the ASA 1-2 categories, as one would expect. About half are presenting directly to A&E, so parents bringing them into the A&E unit, and about a third are being referred via their GP, so either directly to surgical services, to paediatric services, or through the A&E again. And there are about 12% of children who have been transferred from one hospital to another. And the majority of these are because of a need for inpatient beds, inpatient surgical services. There are a few, so it's about 10% who were transferred because of the need for specialist paediatric surgical care. I think there were 8 or so cases out of 1,000 who were transferred specifically because they needed a higher level of care, so HDU or level 3 care that wasn't provided at their base hospital. There were also a few that were transferred because there weren't specialist paediatric radiology services at their base hospital. And there was one case, it was only one that I could see, that transferred specifically for the anaesthetic expertise. Once they're admitted, about 40% are admitted by general surgeons, so that includes adult general surgeons who look after children, and about 40% admitted to specialist paediatric surgical services. The majority are admitted under paediatrics, and there are some other specialties also involved, so paediatric intensive care and paediatric urology appeared a few times. So what happens when they first arrive? It was good to see that the overwhelming majority of sites are using paediatric early warning scores in order to identify particularly sick children, or to indeed identify deteriorating children. About 50%, so about half of children were undergoing preoperative imaging. The majority of those, it was ultrasound imaging, departmental ultrasound imaging, as in performed by radiologists or radiographers. There were a handful of sites who are now actually looking at using point of care ultrasound, and a few other cases in which further imaging was needed. Almost all children are having blood tests prior to surgery, and the median white cell count for children who do end up going to theatre is about 14, with the CRP being elevated is about 42, but a fairly wide spread there. And about 75% of children are having antibiotics administered at that initial point in time. And who's looking after them? So about 55% of children are reviewed by a consultant surgeon prior to transfer to theatre. And for the remainder, the majority, their case was discussed with the consultant, but they weren't necessarily directly involved at the bedside prior to them heading down to theatre. A fair proportion, so almost just over 10%, it wasn't very clear from the notes who was involved in making that decision that the child should go to theatre. Once in theatre, the most senior operating surgeon was the consultant at 60% of cases. And actually, there was a cohort study, so the last big cohort study looking at paediatric appendectomies here in the UK with about 700 cases. It was undertaken about 9 years ago. And at that point in time, it was 30% of consultants present in theatre, whereas now we're recording about 60%. And in terms of the subspecialty, about 40% of surgeons operating these children are specialist paediatric surgeons, and the remainder are on the whole general surgeons who share their care with adults. In terms of the anaesthetist, so 70% of the time there's a consultant anaesthetist present in the theatre. And interestingly, 2% of the time, the most senior anaesthetist is someone who fits into the sort of old school SHO bracket. Obviously, we don't have any information about their level of experience, but that's the grade that they're working at the time. The vast majority of children are having intravenous inductions, with only 3% having gas inductions, and very few are having any sort of regional nerve blocks, so tap blocks, abdominal wall blocks. About 2.4% are receiving those at the moment. In terms of the operation itself, so more than 70% of children are now having their procedures done, started and completed in a laparoscopic fashion, with about 4% converting from a laparoscopic approach to open during the operation. And again, if we go back to the cohort that I mentioned from about 9 years ago, at that time it was about 50% of children were having laparoscopic procedures. Duration of surgery, median about an hour, so on average they take about an hour, and obviously much longer for more complicated procedures. In the post-operative period, the majority of children are going to ward level care, mostly mixed surgical or pure surgical wards. There are a handful who are needing high level care, so critical care, either in a paediatric setting or in an adult setting if not available at the hospital, and a very small number who also are remaining in recovery for a period of time, presumably because of bed issues. About 20% of children are prescribed a PCA or NCA, and about 80% of children are prescribed post-operative antibiotics, mostly for up to 72 hours, but a considerable number are on antibiotics for a week after their surgery. So that data that I've just presented up until now has been the cohort in its entirety, but actually the vast majority of children in whose data we've captured are actually going to theatre for presumed appendicitis. So that's about 92%, and we've got about 8% of children who are going to theatre for other reasons. And so in terms of outcome, it's quite useful to look at the two cohorts separately. So taking the appendicitis cohort firstly, about 84% of children have a very straightforward post-operative course, and about 16.2% are recording complications. If you remember, we're using the Clavien-Dindo complication grading system, grade 1 being a slight deviation from the normal post-operative pathway, possibly needing some additional medications, so antiemetics, analgesia that you wouldn't normally use. So if we consider those grade 2 and above, so the more serious complications, about 6% of children with presumed appendicitis are experiencing these, and about 2% of children are requiring reintervention and needing a second or at times a third general anaesthetic for that procedure. And these procedures are things such as radiological drainage or going back to theatre because of obstruction. And there was one child who was still in hospital 30 days later and had experienced, unfortunately, a single organ failure. The majority of the post-operative complications are infective in nature, so we're recording about a 4% surgical site infection rate, 1% chest infection rate, and there are about 1.5% to 2% of children who are showing signs of having an infection, but the source is not, it's not possible to identify the source, so have been treated empirically. And looking at the histology from the samples received post-theatre, about 30% of children are presenting with complicated appendicitis, so either gangrenous or perforation, and about just under 60% with simple appendicitis. And we're recording a normal appendix rate of about 12%, so a negative appendicectomy rate. So these children have been taken to theatre with presumed appendicitis, and actually the appendix has turned out to be normal on histology. So this compares with, again, with the cohort I mentioned from about 8 or 9 years ago. At that time, they were recording about 19 in their 700 patients. But there was also a large study done, retrospective study done, looking at HES data round about the same time, so from children between 2011 and 2012. And the negative appendicectomy rate in that data set is about 13. So at 12, we're probably sitting round about where one would expect, but it hasn't actually changed over the last, 8-9 years. In terms of length of stay, so those going for laparoscopic appendicectomy, median length of stay is 2 days. And if we turn to the non-appendicitis cohorts, these are children who are not thought to have appendicitis who are taken to theatre for other indications related to an acute abdomen, unsurprisingly actually have much higher rates of complications. So as many as 40% of these children are recording complications as classified by the Clavien-Dindo grading, and that's 28% having complications of grade 2 and above. 10% of children are having to undergo re-interventions, and that's 8.5% of children needing to have a second general anaesthetic in order to facilitate that re-intervention. 5% of children are also recording organ dysfunction requiring either level 2 or level 3 care. Again, the majority of the complications are related to infections, so surgical site infections are much higher at 13% compared with the 4% in the appendicitis cohort. And the empirical infection groups are those in whom it's not possible to identify where the source of infection is, but still needing to be treated is as high as 8%. The length of stay for these children, unsurprisingly, is higher, with a median of 6 as compared with 2 for the appendicitis group. But the good news is the vast majority of children are all discharged home, and this data is censored at 30 days. So within 30 days, I should say this table is for both cohorts, so the entire group. Very few are being transferred back to their base hospital. We had 12% who were transferred at the beginning. So most are discharged home from post-surgery from their surgical centre. With a very small proportion, 0.4%, still inpatients at 30 days. So that's really just an overview in terms of what the population looks like, really. From here on in, we're going to carry on our data collection process and data cleaning. So we may come back to you if there are any issues with some of the data sets that we've been sent through. And the next real step is really to move on to the inferential analysis and try and understand why some of these children are experiencing the complications they are, and see if we can identify some of the risk factors that exist for having a slightly more complicated post-operative course. So thank you very much for listening, and I'll pass you back to Ramani now.
Macie, thank you very much indeed. So if you could stop sharing your screen, thanks, Macie.
Yeah.
So we've had lots of questions come in on the Q&A while Macie and Cyrus have been talking. I hope you can see that the data are really interesting and are going to potentially lead to some quite important discussion about some of the ways in which we treat these children and some of their outcomes. And for example, I was really interested in the differences in the duration of antibiotic therapy after appendicitis, and there's a whole bunch of other things in there as well. So one of the questions that we've had from James on the Q&A is how the negative appendix rate compares with GIRFT, getting it right first time, targets and data. The answer is that I don't know, because I haven't seen the paediatric surgery GIRFT report. Certainly we will share our findings with NHS England Improvement and the GIRFT team when we do our final analysis. This is obviously just an interim analysis of the first 1,000 patients, but I think, you know, Macie's comment that it was 19% in the previous cohort from a few years ago, now around 12%, and we've still got a lot more data to collect. So I think that will be one of, certainly amongst surgeons, one of the important points of discussion. We've had a few questions about how to record certain pieces of data. So, for example, how the post-op length of stay is recorded in days, not hours. Similarly, the date that you, the number of days after admission to hospital when the decision for surgery is made, that is also recorded in days rather than hours. Other questions which have been answered, just so that you know, there's an important question about how retrospective consent can be gained, whether it can be by post, which the answer is yes, and also whether we can use retrospective consent for any missed patients to which the answer is yes, as long as the patients had their surgery after the 1st of March 2020 and after your site received the green light to enter the study. Cyrus has answered some questions about the PID spreadsheet. So we will be asking you to submit these spreadsheets with a deadline of the 1st of July. We'll write to you all with further details of this, just so that we can start to get that data in and start to look at some of the stuff on there as well that is useful for the analyses that Macie is going to be doing in due course, for example, things like gender. So we will write to you in the next week or two to explain exactly when we will be asking for these spreadsheets to be submitted in the first instance in the next month or so, and then we will ask for that data again at the end of the study, which will be at the beginning of next year. Couple more questions which have come in just now. I think those have both been answered. So I think, unless I'm hoping that if anybody else has got any questions, there's another one that's just come in. So hello Simon. So the suggested GIRF target is 5% for negative appendicectomy rate and low rates linked to high ultrasound rates. So it would be good to look at the non-negative appendicectomy group for imaging rates. This is the sort of discussion that we will find really, really valuable when we start to look at the data. As I say, Macie has presented a snippet just to pique your interest, which it clearly has done. But once we've closed the study, we will look at all of this. And certainly, clearly, at the moment, the negative appendicectomy rate is higher than hoped for. And so certainly we will look at imaging rates and any other factors which may predispose to a negative appendicectomy finding. So if there are any other, unless there are any other questions, I will be looking to close this webinar in the next couple of minutes. We will put in the Q&A, Karen, I'd be grateful if you could enter both the web address for the study website and also the email address for the generic study email address if you've got any queries for us. One question that's just come in, do we want to know if any patients are readmitted following admission? No, we don't, because that's one of the reasons why we really need this patient identifiable data from you, because by collecting that, we'll be able to get the sort of information that you've just described, which is sort of post-discharge readmissions to hospital. We'll be able to get that from national administrative data sets without you having to trawl through notes and so on to find it. So so we don't need any data to be collected after the child has been discharged from his or her primary admission. So I think if that is all the questions that we've got so far, then we will close the webinar. We will send out to everyone that registered today both the link for the recording of this, which will be on the website, and also the useful web addresses and email addresses for you to contact us. Thank you very much indeed for your support for this study so far. Thank you for everything that you've done for your patients and for the NHS over the last year already. And we'll look forward to working with you on this study over the next 8-9 months before we close. Thank you very much indeed. Have a good day.